Chapter 52 discusses disorders of skin integrity and skin function. So to start out, I want to ask you to please review the different types of skin lesions. So really kind of know the skin lesion types, meaning if I say this skin disorder creates papules and pustules, or a defining characteristic of this skin disorder is lichenification, you should be able to kind of identify or picture in your head what that might look like. There is a table in your textbook, table 52.1, that identifies the different types of skin lesions, gives some descriptions of them. It has pictures. It has some of the skin disorders that those types of skin lesions are usually associated with. So I'm going to recommend that you review that. I'm not going to directly test you on that. Like I won't give you a question that says, which of the following descriptions is a papule. But within different skin lesions, I might talk about the clinical manifestations of a skin condition. And if you don't know what those individual words mean or what they describe, it might be kind of difficult for you to answer the question. So it's really a foundational piece of kind of the rest of the clinical manifestation conversations we're going to have. So again, know things like macules, papules, plaques, nodules, vesicles, pustules, cysts, scales, crusts, keloids, and lichenification would be some of the things that I would maybe review from that table and have a general understanding of what they are, how to describe them and what they might look like. Okay, so we're going to just jump into some of the skin disorders. I'm only going to cover a very small subset of the skin disorders in the book. Skin disorders are extremely wide-ranging. I think it's very difficult to kind of really memorize them all and be really good at identifying them unless you see them all the time. The better thing to think about is if you encounter a skin disorder and you're not really aware of what it is, really cue in on the types of lesions that are there, use those good descriptors of the lesion types, and then search by those types of lesions to be able to try to match them up with the disorder. I think that's, again, kind of the best way to go forward with identifying skin lesions when you're just not going to be able to memorize or remember what they all are. So I'm just going to hit on maybe some of the more common ones that we see, or some of the kind of like traumatic or acute skin kind of things that we see that might require like more advanced treatment and hospitalization, meaning that you would maybe encounter those a little more often in patients. But anyway, I'm going to start with acne because acne is an extremely common skin condition that has a lot of maybe not medical consequences for patients, but things like psychosocial consequences, as well as things like consequential acne causing scarring that can be sort of a prolonged issue for patients. And those are the reasons why acne is kind of an important subject to talk about as far as treatment, because again, it's not really that it's something that's medically dangerous, but it can cause a lot of psychosocial kind of pain and isolation for people who suffer from it. So acne is overall a disorder of what we call the pilosebaceous unit, and that unit has a tiny vellus of hair. So you can see that kind of here, this little hair shaft, as well as a sebaceous gland. And the sebaceous glands are largest on the face, the scalp, and on the scrotum. But they are also present in all areas of the skin except for the soles of the feet and the palms of the hand. So those are the only places we don't have sebaceous glands. So you can kind of see that here, the hair shaft into the hair follicle, and then it's connected to this little kind of sebaceous gland right off to the side. And this is where that kind of whole thing sort of opens up on the surface of the skin. So sebaceous cell proliferation and sebum production, which is what sebaceous glands produce, are uniquely responsive to direct hormonal stimulation by androgens. And remember, in men, testicular antigens are the main stimulus for sebaceous activity. And in women, adrenal and ovarian androgens maintain that sebaceous activity. So this is the kind of different types of acne lesions that we might see. So acne lesions can be non-inflammatory in nature, or the comedones. These are plugs of material that accumulate in sebaceous glands that open to the skin surface. So these are things like whiteheads or blackheads. So again, really not inflammatory, but that opening of that sebaceous gland to the skin becomes clogged. In inflammatory conditions, we see things like papules, pustules, nodules, and in severe cases, maybe even cyst formation. So the inflammatory acne looks inflamed. Um, these are believed to develop from the escape of sebum into the dermis, and that irritates the skin itself and affects the fatty acids contained because of the fatty acids contained in the sebum. And so that's why these are inflammatory in nature. So when we talk about acne treatment, sometimes we see patients who will actually have things like whiteheads and blackheads extracted, where those little plugs are removed. And when done with care, that is potentially okay for non-inflammatory. But in the case of inflammatory, we really encourage patients not to disturb, pick, or open up any of these papules and pustules, because that causes that sort of sebum to further, cover different areas of the skin. And because that is the actual irritant, it can make all of that inflammation worse. So in inflammatory conditions, it's really important to encourage our patients not to pick at or open up any of those lesions again, because it makes this inflammatory condition even worse. So there are kind of two main types of acne that I'll mention. Acne vulgaris, which is a chronic inflammatory disease, again, of that pilosebaceous unit. So this is the type that happens very commonly in adolescence and early adulthood. So that's really what we think about when we think about that kind of adolescent acne type. Acne conglobata happens usually later than adolescence, and it's usually quite a bit more severe than acne vulgaris. It is also more commonly that it spreads to the back, the buttocks, and the chest, beyond that of just the face, which is usually where we see the primary lesions of acne vulgaris. Patients, while this is to a lesser extent, can also get lesions on the abdomen, shoulders, neck, face, arms, and thighs, so much more wide-ranging. And in acne conglobata, the treatment can be things like debridement, systemic corticosteroid therapy. We can also use oral retinoids and systemic antibiotics. We'll talk about vulgaris treatments in a moment. Other things to know about acne conglobata: the comedones or the cysts have multiple openings rather than just kind of one opening that we see in acne vulgaris. They can also evolve into things like large abscesses, and they can have like interconnecting sinuses between them. So much more severe inflammation and wound development in this disease. There's often more significant discharge as well that can be sometimes odoriferous, serous, or mucoid, can also be quite purulent. And because of the increased severity, sometimes affected persons even get anemia and elevated white blood cell counts, increased erythrocyte sedimentation rates, increased neutrophil counts. So much more significant systemic effects of this inflammatory condition. So for acne treatment, for just general acne vulgaris, again, the big thing is to avoid traumatizing the skin. So not picking at any lesions. Extraction is only appropriate for non-inflammatory conditions. Otherwise, we can spread both the sebum as well as acne-causing bacteria to other areas of the skin. Other things that can traumatize the skin that would go into this category are things like using really hot water on the skin. It should just really be kind of lukewarm. You don't want to use anything really hot because it dries out and irritates the skin. You want to encourage patients to just pat dry the skin rather than vigorously rub or try to exfoliate. That can also cause a lot of irritation. You really need to treat the skin gently and with a lot of care. One standard of treatment is benzoyl peroxide. This is the active ingredient that is found in many acne washes, and this is something that dermatologists will recommend for either daily or twice a day cleansing of the skin for patients with acne. We can also use topical retinoids, excuse me, that's things like adalipine ointments. There are over-the-counter preparations that I think are maybe like 0.1% that may be helpful in mild cases. In more severe cases, we have prescription strength, stronger retinoids that patients can use topically. We also use topical antibiotics because there is a bacteria, P. acne, that is common in these lesions that topical antibiotics can sometimes help to reduce. So sometimes patients might use like a retinoid in the morning and then maybe a topical antibiotic in the evening and kind of trade those off for acne treatment. In severe cases of acne vulgaris or in conglobata, we can use systemic antibiotics, especially for severe outbreaks. And we can also use oral retinoids like Accutane for the treatment of more moderate to severe acne vulgaris. Okay, so now we're going to talk about the allergic and hypersensitivity dermatoses. So we're going to start with contact dermatitis. And we talked about contact dermatitis a little bit when we talked about some of the hypersensitivity reactions. So this is really allergic contact dermatitis. So this results from those cell-mediated type 4 hypersensitivity responses. There are around 2,000 identified causes of allergic dermatitis. So this can be very common, and oftentimes patients might not even know what they came into contact with that caused this because this reaction to it might be so delayed that they're not even quite sure. But some of the really common things that cause it are like poison ivy, poison oak. The metal nickel is often a culprit here, and a lot of various components of things like dyes and fragrances. And some people are just more sensitive to different things that come in contact with the skin. So some people who develop a contact dermatitis from one allergen might develop it from a lot of different allergens just because, again, they're more sensitive to those things. So these are two hypersensitivity, one on dark skin and one on lighter skin. But the type of lesions that we see here are things like vesicles, so small skin lesions with fluid inside of them surrounded by erythema or redness are pretty common skin lesions seen with dermatitis. Those lesions can also get larger, fluid-filled, so things like bulla, which are similar to vesicles, just larger in size. The other type of hypersensitivity dermatitis is irritant contact dermatitis. These are usually caused by chemicals that directly come in contact with the skin that cause irritation. In this type of dermatitis, there's no allergen identified. We see dryness and erythema, and also things like scaling or fissures, and sometimes vesicles in contact dermatitis. Then we'll talk about some of the allergic and hypersensitive, some more allergic and hypersensitivity dermatosis. So things like atopic dermatitis, this is atopic eczema. This is an inflammatory skin disorder that's characterized by poorly defined erythema, so meaning that there's erythematous regions on the skin that don't have any kind of like distinct borders. They can also experience things like edema, vesicles, and vesicles that even weep or kind of open up and seep fluid, especially in the acute and early stages of eczema. This disorder, atopic eczema, is viewed as a skin disease that often predisposes patients to allergies. So we see eczema on one example on dark skin here and an example on light skin here. Oftentimes we see a significant connection between early eczema and the development of asthma as well. And the connection there is asthma is also a condition that's usually kind of allergen driven. And so that's where we think that this link really is. So approximately 30% of children with atopic dermatitis develop asthma, and 35% will develop allergies in adolescence and adulthood. So significant link between those kind of three conditions of eczema, allergies, and asthma. Eczema in adolescents and adults, these patients usually have dry red patches, usually on the face, neck, and upper trunk. We differentiate this from psoriasis, which we'll talk about momentarily, because in psoriasis, there's a thickening and like kind of a demarcation or a distinct kind of line associated with psoriasis conditions. Acute flares of eczema may present with red patches that are weepy, shiny, or lichenified. Treatment usually for eczema focuses on the underlying cause. So when people have acute flares, they're often precipitated by things like stressful conditions or other conditions that might stimulate the immune response. So those would be things we'd want to try to prevent. We can also use things like topical steroids for eczema if it's severe. We also want to monitor these patients for secondary skin infections, especially if they have open areas on the skin that might be kind of weeping. We can use things like emollients. Emollients are topical agents that help to kind of reduce dryness and soften those areas of eczema. Antihistamines topically can be used if those areas become itchy. We do want to encourage patients not to kind of rub or itch or scratch at those areas because they can make open areas worse and cause further skin damage, leading to increased risk of things like infection. If a skin infection were to occur and it was significant, we could use systemic antibiotics for that. And we can also use short courses of oral corticosteroids for severe flares of eczema. So now we're going to talk about the papulosquamous dermatosis. So these are conditions that are characterized by circumscribed red thickened plaques, often with an overlying silvery white scale. So scaling papules and plaques. And we're going to really focus on psoriasis here. So papulosquamous dermatosis or psoriasis is a common chronic inflammatory condition with a genetic component. So this is often a genetically predisposed disorder. What we see is this increased epidermal cell turnover with marked epidermal thickening. And this is a process that we call hyperkeratosis. There's no cure for psoriasis. There are some topical and now oral treatments that can significantly reduce outbreaks of psoriasis. And we've also seen success with the use of phototherapy in its treatment. So these are some pictures. This is what psoriasis can look like on lighter skin. You see this kind of demarcated area where the very clear separation between psoriasis and affected skin and normal skin. You can see kind of that inflammation or that kind of redness with that kind of patching and silvery scaling over the top. And this is what it might look like on brown or darker skin. Maybe a little more difficult to pick up some of that inflammatory stuff, although you can see it within those silvery lesions, but you can see still that clear kind of demarcation between healthy skin and psoriasis affected skin. With treatment, some of the topical agents we use, again, things like emollients that can kind of soften the skin. We can use different keratolytic agents, which can kind of break down or kind of eat away at those hyperkeratinized agents. So those are like peeling agents, like salicylic acid is probably the most widely used agent here. Um, there are things called coal tar products. Coal tar is the byproduct of the processing of coke and gas from coal, and it is one of the oldest yet most effective forms of treatment. Anthralin is another form of treatment. It's a synthesized product from something called Goa powder. That's derived from Brazilian Araroba tree bark, and that's a topical treatment that's been used for a long time as well. There's also calcipotriene. That's a topical vitamin D derivative that can be really effective for the treatment of psoriasis. And again, things like systemic therapy, like phototherapy or photochemotherapy. In some cases, we can also use methotrexate or oral retinoids, or oral corticosteroids, and oral cyclosporine are some other systemic treatments for psoriasis. And we're going to move on to talk about some of the skin conditions that are caused by exposure to the sun or to ultraviolet light. So we're going to start with discussing the different types of ultraviolet light. There's UVC rays. These are really short ultraviolet rays that don't really pass through the Earth's atmosphere. So these are really not as clinically significant as far as skin conditions as UVB and UVA rays. UVA rays are the longest ultraviolet rays, and these can pass through like window glass. These are referred to as our sun tanning rays. So because they're much longer and they can penetrate much deeper, UVA ray is really around all the time. And it is often thought to be more causative of things like skin cancer, again, because it can much more deeply penetrate the skin. UVB rays are those responsible for nearly all of the skin effects of sunlight. So these are the things that are most commonly cause like things like sunburn. And they cause sunburns that are that kind of delayed reaction we see in sunburn that causes it to really kind of persist past the initial exposure to sun. So the effects of ultraviolet rays of sunlight, those acute effects are those that are short-lived and reversible. So things like erythema or hyperpigmentation of the skin, and injury to things like Langerhans cells and keratinocytes in the skin itself. So these are things like sunburn, suntan, darkened areas of the skin. Those are the acute effects of ultraviolet light. The chronic effects are their direct damage to the skin cells themselves. So ultraviolet lights really accelerate the effects of aging on the skin. They not only change the upper layers of the skin, causing dark spots, but they can also damage things like collagen within the skin, which leads to kind of that loosening of the skin that leads to things like wrinkles and sagging of the skin in general. So those are the overall effects of aging. And they also produce those changes to the skin that predispose us to the development of skin cancers. So sunburn is an acute effect of UVA, UVB exposure. So it is excessive exposure of the epidermal and dermal layers of the skin to ultraviolet radiation. So ultraviolet radiation, those rays can penetrate below epidermal layers into the dermal layers of the skin itself. This results in erythematous inflammatory reaction of the skin. So that kind of classic redness and burning that we see with sunburn. If severe, that inflammation can also cause blistering, and it can cause systemic effects as well, like chills, fever, malaise, and pain. This is often more common in really severe forms of sunburn. So the best way to protect from this is to protect yourself from the sun. So to avoid direct sun exposure. So use of things like protective clothing. Clothing is often marked with UVA and UVB protection. That's important. There are some types of clothing that UVA and UVB lights, rays especially, can penetrate right through. So even with covered skin, if you don't have protective clothing that can prevent penetration from those rays, you can still get exposure. And so all skin should really be covered, including the head. So using things like hats that will protect the scalp as well as the face from UVA and UVB exposure. And then encouraging the use of sunscreen, and sunscreen really at all times. Sometimes I think, we encourage people to put on sunscreen if, they know they're going to be out in the sun for extended period of time. But a lot of the changes that we see in skin, both age-related changes as well as that predisposition to cancer formation, is really caused by more incidental day-to-day exposure. So, maybe people are only out in the sun for 15 to 30 minutes, and so they don't think of sun protection. But all of those changes, all of that exposure really starts to add up over time, and is probably more consequential than, those kind of long sun exposures where people might actually use some form of sun protection. So it's important to encourage people to really use daily sunscreen on exposed areas, even if they think that it's going to really be inconsequential exposure. So that there are different types of sunscreens. Many have chemical agents that absorb both UVA and UVB rays, and you want to make sure when using a sunscreen that it protects against both types of ultraviolet rays. There are also physical agents, things like zinc, and other kind of like metals within sunscreens that can physically protect. So you're not absorbing chemicals into the skin that can protect. It's more of like a protective barrier directly on the skin itself. We can also sometimes use biological agents that reduce inflammation. And again, you really want any lotions you use to be broad spectrum. Okay. A little bit more about avoidance too. We talked about incidental exposure, but also it's important to understand that there are certain times of day where the sun is strongest, usually midday. So usually between like 10 to 11 and between like 2 and 3, depending on where the sun is really in the sky. Those are the times of days where sun exposure is going to produce the strongest UVA and UVB rays. And so those are the times of day where it's especially important to use skin protection to prevent exposure. You may have also heard this in your pharmacology course, but I'll just reiterate it here, that there are certain drugs that can increase photosensitivity. And so this is an exaggerated response to ultraviolet light when you take these drugs and then combine them with sun exposure. So people who are photosensitive will be more prone to things like sunburn when exposed to UVA and UVB rays. This condition usually resolves itself when the drug is withdrawn, but for some people it may linger beyond that time. And so if anyone is taking a drug that has photosensitivity as a potential side effect, they should especially be encouraged to avoid UVA and UVB rays. So don't go out during midday. And if you do go out, really use good sun protective measures, both maybe sunscreens as well as protective clothing. Some drugs that are examples of things that can cause photosensitivity, there are some anti-infective or antimicrobial agents. Antihistamines can sometimes do this. Many of our antipsychotic drugs, certain diuretics, certain hypoglycemic agents, some of our non-steroidal anti-inflammatory drugs, some of our topical agents that we just talked about for things like acne. People under treatment for acne with things like topical agents like retinoids should really be encouraged to use special care. They should have sunscreen on their face at all times because they are going to be really prone to sunburn and damage. So again, one of the major reasons why we want to reduce UVA and UVB exposure is because of the risk of the development of skin cancers. So for people who have nevi or moles, these are benign tumors of the skin, but these can also predispose people to the development of skin cancers. And there are really two criteria here that correlate nevi with melanoma risk. People with a high nevus count, so they have a lot of nevi all over their skin, have a much higher risk of the development of melanoma. And also people who have relatively large nevi, they are also more at risk for the development of melanoma. So because of the possibility of malignant transformation, any mole that undergoes a change warrants immediate medical attention. And what we mean by change is things like changes to symmetry. So here's a normal nevi, and when they become abnormal, the outer borders become asymmetric. They're not nice and rounded. We see that again, that overall asymmetry. Also, if their borders change and become less distinctive, so here's a normal nevi as opposed to an abnormal or possibly melanoma nevi. If we see significant color changes, that's also a change that can be associated with melanoma. Or if the diameter changes, they grow, or if they start to overall evolve. This picture is kind of harder to see, but you see a change from very small, a couple clusters of very light colored nevi, to a cluster where there are more nevi that have formed, some of which are larger in shape with asymmetrical borders. So these are all examples of change that would require immediate attention. And we want to also let patients with many nevi know that they should be observing their own moles to observe and report things like changes to size, thickness. Other things that they might notice are when these nevi become really itchy, or if they start to bleed and won't stop. So there are three major types of skin cancer. There's malignant melanoma, which we kind of alluded to already with our discussion of nevi, but these are rapidly progressing malignant tumors of the melanocytes. So the specific type of cells that change here are those melanocytes within the skin. And so this is an example of the formation of a melanoma and what that looks like through the layers of the skin. Malignant melanomas are more common on fair-skinned individuals. They tend to be more susceptible. So anyone who freckles or burns really easily would be the most at risk for the development of malignant melanoma. Other risk factors are people who have had severe blistering sunburns, especially in early childhood, or who experience intermittent intense sun exposures. These really contribute to increased susceptibility to melanoma, especially in young and middle-aged people. Roughly 90% of malignant melanomas in white skin occur on sun-exposed skin. In darker skinned people, melanomas often occur on non-sun exposed areas, such as like the mucous membranes of subungual, palmar, or plantar surfaces as well. So the spots where we see malignant melanomas are often different in patients with darker skin. Okay. Basal cell carcinomas, you can see that kind of in the middle picture here, are neoplasms of the non-keratinizing cells of the basal layer of the epidermis. These are the most common skin cancer types in white-skinned people. And then there is squamous cell carcinoma. These are the second most frequently occurring malignant tumors of the outer epidermis. And so you can see that here, how squamous cell is really kind of those outer layers of the epidermis. So here's malignant melanoma again. We use that ABCDE rule in diagnostics. So asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolution. Other changes we sometimes see are bleeding, itching, and non-healing ulcers. We really want to encourage patients to self-examine again, especially those fair-skinned patients who have a lot of nevi, who have maybe had severe sun exposure in the past, or a lot of high-risk sun exposure, because early detection is really key to the successful treatment of malignant melanoma. If we catch it early, we try to excise it completely through surgical intervention. And then we also assess lymph nodes in the area to see if this cancer has invaded and spread through the lymph. If it has, then we can use systemic chemotherapy The problem with malignant melanoma is that once the disease becomes advanced, it is really hard to treat and cure. So advanced malignant melanoma has a high mortality rate, which again is the reason why early detection is really important. I also would say that early detection from self-examination is good, but we also want to encourage those patients who are high risk, starting usually in maybe late adolescence to early adulthood and then into middle age, to have um, maybe even yearly skin checks by a dermatologist to monitor for the development of malignant melanoma. Squamous cell carcinomas, you can see those kind of pictured here, are an invasive type of of skin cancer that can also spread to local lymph nodes. They're usually red scaling keratotic lesions that are slightly elevated with irregular borders, so you can kind of see that here. And they usually develop looking like kind of a shallow chronic ulcer. One of the things that dermatologists will tell you is that if they have patients who come in with complaints of an ulcer on their skin that just won't heal, one of the early things that dermatologists will think about first is the development of squamous cell carcinoma. If that lesion is also on a sun-exposed area, that's also usually a pretty good sign that it's a squamous cell carcinoma. Treatment is largely removal of the lesion, so to cut that lesion out completely, and then to look for the possibility again of any lymph node spread. The final type of skin cancer we'll talk about is a basal cell carcinoma. These carcinomas don't typically metastasize, but they can spread very wide and very deep within the layers of the skin. If you remember back to that picture where I showed you the different where areas of skin that these can invade, a basal cell carcinoma was kind of that middle lesion that dug itself deep down into the skin layers. So while these don't metastasize, they can get so deep into the skin that their removal, if they've been growing for quite some time, can cause kind of a lot of like scarring and disfigurement of the skin itself, because of like kind of like depth that we sometimes have to go to remove them completely from the tissue. They, just like other types of skin cancer, are usually found on sun-exposed areas of the skin, but they are highly curable if they're detected early. Surgical removal, again, is the most really important treatment here, but can cause a lot of scarring and disfigurement if these are really deep lesions. Then we're going to move on to talk a little bit about burns. So the effects and complications of burns fully illustrate the really essential functions that the skin performs. So the skin protects the body from damaging elements in the environment, and it is also instrumental in maintaining that constancy of the body's internal environment. The skin separates the internal environment from the external environment. So its main functions, again, are protection and maintaining that internal constancy. So when we talk about internal constancy, it's things like maintaining fluid balance, maintaining things like thermoregulation. Those are a couple really important things. And then with protection, again, it's things like preventing the skin from drying out. Maintaining fluid balance also falls in there. And the big piece is really protecting the internal environment from things like infection. And so with burns, we lose a lot of those protective elements. So we talk about types of burns in degree. So with something like a first degree burn, this is a superficial or sometimes termed partial thickness burn. It really only involves the outer layers of the epidermis. So first degree burn does not cause disruption to the skin that really changes its ability to act as a barrier. So these are usually pretty mild burns that we can just treat with maybe topical creams to reduce like inflammation and pain, to prevent them from drying out, and by just maybe covering those burns and allowing them to heal. A second degree, or sometimes also partial thickness burn, involves the epidermis and various layers of the dermis. And then there is also second degree full thickness burns that involve the entire epidermis and dermal layer. So in the picture here, you can see this is normal healthy skin. Here's our first degree burn where we only have the outer layers of the epidermis involved. And here is a second degree burn where we can get into kind of maybe some of those dermal layers if we have kind of a full thickness second degree. And sometimes we even see things like blistering that are forming in that type of burn. If we have blister formation, then that patient can still often maintain that barrier function of the skin. If blisters form, we usually leave them intact because otherwise, if you open those up, you've taken away that skin barrier. Another thing to know about second degree burns is that they are often quite painful because the nerve fibers within the skin are still intact. And so now we've kind of exposed them directly to that area of burn. So these second degree tend to be kind of the most painful type of burn that someone can experience. A third degree burn is a full thickness burn that extends all the way into the subcutaneous tissue and may extend even deeper into muscle and bone. Okay, so the epidermal and dermal layers are now completely gone, and we've burned all the way down into the subcutaneous tissue or deeper. So oftentimes third degree burns are not particularly painful, but patients do still have a lot of burns with this, or pain with this type of burn, because they're usually mixed with other types. So often we have areas that are all kind of commingled of second as well as third degree burns. Okay. If someone has third degree burns, they will typically require skin grafting if those lesions are greater than about 1.5 inches, because those lesions will not heal on their own otherwise. We'll talk a little bit more about skin grafting when we talk about treatment, but these are the ways that we describe the different degrees of burns. Again, first degree, second degree partial, second degree full, and third degree full. Okay. When we talk about burns, we often also talk about estimation of the total body surface area involved in a burn. So we usually use something called the rule of nines, where we break the skin area up into different sections of about 9%, and then look at how many of those areas are burned and kind of add those percentages together to give a total burn area. So these are, again, multiples of 9. So the face is 9%, arms are 9%, legs are about 18%, anterior trunk 18, posterior trunk 18, the head itself is 9%. So if somebody had burns that covered their entire anterior chest as well as their entire, right arm, they would have 18 plus 9%, so 27% burned. And so that's how we, again, calculate that kind of percentage burn, which is common nomenclature when we're talking about the extent of a burn injury. But there are other kind of factors involved in this. I mean, the reason that we talk about like thickness of burns and percentage of burn is that the kind of complications that we see, those rates and severity go up with the extent of the burn. So it's important for us to be able to kind of describe extent of burn so that we can accurately kind of predict and monitor and treat for the complications that go up as extent of burn goes up. But there are other factors besides like percentage and depth that can increase severity of burn. So things like age, the very young and the very old, if they have burns, with lesser extent, they often have more complications that you might see in people with different ages. Other things like location. So burns, for instance, to like the face, neck, and trunk often have increased severity because those patients are potentially more likely to develop things like severe respiratory complications associated with burn. So even though they may have a lower percentage of burn that someone who maybe has experienced a lower body burn might experience, they're also more likely to develop some of the more potentially serious complications. If burns happen along with other types of traumatic injuries, they can often be more significant as well. So things like, blunt force trauma or interior trauma or trauma from falls, something else along with the burns would make it more significant. And also patients with maybe pre-existing conditions. So maybe patients with pre-existing cardiac or lung disease or pre-existing renal disease are going to be more impacted by some of the long-term systemic effects of burns, like fluid management problems or lung damage. Those patients would be at higher risk, okay? Because these factors can, again, increase the assessed severity of the burn as well as the length of treatment, okay? Another example here is something like a first-degree burn might be reclassified as a more severe burn if other factors are present, such as burns to like the hands, the face, the feet, or if there's like an inhalation injury, or if it's from maybe an electrical burn or some other kind of trauma. Other examples, things like genital burns almost always require hospitalization because of the edema that they can cause, leading to difficulty with urination, and the location also complicates like management of a bacteria-free environment. So again, just some other examples of how just classifying by degree and total body surface area might sort of oversimplify our discussion of severity of burn. So the systemic complications of burn tissue are often some of the things that can become more significant to our patient even than the burn itself. So things like hemodynamic instability. We sometimes term this burn shock. When someone is burned, fluid is lost from the vascular, interstitial, as well as the cellular compartments. And the amount of fluid lost is directly related to the amount of skin damage. So how deep those burns are and how extensive they are throughout the body. And that overall significant loss of fluid can lead to hypovolemic shock if that fluid volume loss is significant enough. So one of the hallmarks of treatment, especially for significant burn where we've lost a lot of that vascular, interstitial, and cellular compartment of fluid, is to aggressively fluid resuscitate these patients to prevent hypovolemia. There's also impaired respiratory function. Often when people are burned or are in burn-causing environments, there's respiratory damage from things like chemical and smoke inhalation that can damage the mucous membranes, causing bronchospasm and edema in the respiratory tract. These effects can also be delayed and can happen as long as 24 to 48 hours post-burn. So even if someone comes in from a burn initially and they look respiratory intact, it is important to monitor them for respiratory complications, within that 24 to 48 hour period. And it's especially important if the location of that burn injury is again around the head, neck, and face, okay? The other component that can increase the risk of impaired respiratory function is how long someone was exposed to things like smoke inhalation or chemical inhalation. If someone has been in that environment for an extended period of time, they're going to be more likely to develop problems with respiratory function. Another systemic complication is hypermetabolic response. The stress of a burn injury increases metabolic and nutritional requirements. Patients who are burned also hypersecrete things like stress-related hormones such as catecholamines and cortisol, and that also increases their metabolic needs as they, try to maintain homeostasis. Heat production is also increased in an effort to balance heat loss from that burned area. And so those are things that also increase that metabolic rate. Hypermetabolism in these patients is characterized by increased oxygen consumption, increased glucose use, increased protein and fat wasting. These are all characteristic responses to burn trauma. Also, patients who develop infections because of burns increase that hypermetabolic need. So these patients are going to have a much higher need for, again, things like fluids, caloric intake, because they're just going to be burning through those things so much more quickly. Okay. Destruction of the skin also prevents delivery of cellular components of the immune system to the site of injury. So that's another kind of issue here. And that leads to things like potentially sepsis. So when the skin is no longer intact, it's really open to bacterial infection. We also lose the protective skin flora that acts as a barrier. So all those things predispose to things like infection and sepsis. And finally, you see a lot of major organ dysfunction, so things like kidney dysfunction, especially in hypovolemic patients. We can see the development of GI ulcers largely because of that increased stress response of catecholamine and cortisol release. They can also develop a lot of neurological and musculoskeletal dysfunction. We'll talk about some of those things a little bit further too on the next slide. So for treatment of burns, one of the most immediate things we need to do in that immediate, when the burn is happening, is to stop the burning. So get them out of whatever environment that's causing the burn. If there's active fire, put it out and immediately submerge and start to try to cool the skin and tissue. That is a big hallmark of burn immediate treatment. The next type of emergency care consists of resuscitation and stabilization, usually with the aggressive use of intravenous fluids, while also trying to maintain cardiac and respiratory function. So if we're aggressively giving fluid, we have to monitor closely for things like fluid overload and cardiac systemic functioning. And again, because there's that high risk of respiratory injury, we have to watch respiratory function very closely. Once a patient is hospitalized, again, the treatment regimen really focuses on continued maintenance of cardiorespiratory function, also the alleviation of pain, extensive wound care, and emotional support. Okay. Intermediate and long-term treatments depend really on the extent of injury. One big goal of treatment is to protect the patient from desiccation or drying out because of the loss of that skin barrier. Another treatment that we sometimes see is something called an escharotomy or a fasciotomy, especially in the case of what we call circumferential burns. If the entire circumference of like a limb, like a leg or an arm is burned, as that skin is burned, it can kind of tighten up and create like a almost like a pressure or like a tourniquet around that area of tissue that can start to cut off blood supply and cause further necrosis and damage to the skin. And if that is happening in a significant way around, again, a limb, it can also happen on the trunk. If somebody has circumferential burns to the trunk, that kind of pressure can exert itself onto the lungs and prevent good lung inflation. It can cause respiratory distress. And so the treatment for that is to create like kind of a lateral incision into the skin itself to open up that area of kind of like eschar and dead tissue so that we don't get that sort of like almost tissue tourniquet formation in those areas. Okay. And then again, reminding and mentioning that a systemic infection is a very high risk in these patients. It's actually the leading cause of mortality. Most patients with extensive burns, what ends up causing their death is some sort of a systemic infection, overwhelming systemic infection with sepsis that we're unable to treat. So finally, some other treatments of burns. One is skin grafting. Again, remember if there's third degree burns that are larger than 1.5 inches in diameter, we will need to skin graft to get any sort of treatment. Also, microbial surveillance and protective isolation. Patients with extensive burns are kept in strict isolation to prevent infection. We often give them prophylactic antibiotics as well. To remind too that they often need extensive wound care. A lot of the time, patients with extensive burns spend an extended period of time in intensive care units, even long after they're maybe cardiorespiratory stabilized, because the wound care can be so significant and time consuming. We also use positioning, splinting, and PT to prevent contractures. That skin, due to its changes, often predisposes these patients to contractures because the skin is kind of tightened up. And so if we don't loosen and work those muscles and joints, contracture is a significant risk for those patients.